Hi everyone. I would like to introduce Dr. Todd Herrenkohl, who is a professor here at the University of Michigan School of Social Work, as well as the Marion Elizabeth Blue Professor of Children and Families. His scholarship focuses on the correlates and consequences of child maltreatment, risk and resiliency, and positive youth development. His funded studies and publications examine health risk behaviors in children exposed to adversity, protective factors that buffer against early risk exposure and prevention. An international scholar, Dr. Herrenkohl, works with policymakers, school and child welfare professionals, and community partners to increase the visibility of application and sustainability of evidence-based programs and practices in prevention of social, emotional, trauma response care. He is also on our faculty executive community, and so I'd like to thank him for taking the time to come speak.
Yeah, it was thanks. Well, I do appreciate the opportunity to talk with you today. Hopefully what I have to say kind of resonates with interests and ideas that you all have, and feel free to jump in and interrupt as I go through. I think what I will present is about 30 minutes, give or take a few, and so hopefully we'll have some questions at the end for discussion or dialogue. So I'm going to cover a few different things. We will talk a little bit about adverse childhood experiences. I want to say a little bit about a longitudinal study that I oversee. It's called the Lehigh Longitudinal Study. We also call it the Lehigh Family Study, and it's focused on child abuse and neglect and the ways in which individuals experience and then overcome, in some cases, the early child adversity that they encounter. I'll then touch on prevention and intervention programs just briefly, sort of referring very specifically to a public health framework. And then end with just a couple of comments about trauma-informed practices, which is an area that I'm working in increasingly. So how many of you are familiar with the ACEs study, the study that Vince Felitti and others have done? Yeah, so this was a study done late 1990s that really put this kind of concept of ACEs on the map. ACEs are not, it wasn't even then, or weren't then, a new thing, but this study sort of brought to light just the prevalence of ACEs, and in that way, I think made a very strong contribution to the literature. So what they did in this study, for those who aren't familiar, they sampled about 8,500 adult respondents from a large health maintenance organization. I actually think it was Kaiser Permanente, if I recall correctly. And so they asked these individuals who ranged in age from 19 to 92, so broad age range, what they recalled about their early life experiences, particularly around different forms of adversity, and those things are listed here. So different forms of abuse, physical, psychological, sexual, whether or not they had a household member who had been who had used drugs and alcohol, whether they had household members who had a mental illness, whether they had they witnessed their mother being treated violently, and whether there was a member of their household who had been imprisoned. And so individuals, retrospectively reported on these things. They then documented how many of the different forms of adversity individuals encountered. They added them up, and then they compared them to a bunch of different health risk and chronic health indicators. And what they found was that about half, just over half, 52% of respondents reported one or more adverse childhood experiences. Individuals who experienced one ACE were also more likely to experience others. So that is a very common finding, actually, in the literature on child abuse and neglect, that there's a great deal of overlap or co-occurrence in different forms of adversity. The likelihood of health risk behaviors that included smoking and activity, suicide attempts, and alcoholism, as well as disease indicators, were much higher among those who experienced multiple adversities in particular. So they compared, again, a fairly simple kind of analytic approach. They compared individuals who had 4 or more ACEs to those without any, and they derived then odds ratios that are reflected here. There have been other studies like it since. In fact, some of you may be familiar with the BRFIS, the Behavior Risk Factor Surveillance System that is run by the Centers for Disease Control and Prevention. Melissa Merrick is the first author. She's a good friend and colleague who I've worked with at the CDC for a number of years. She and her colleagues published this very recent study, actually, published in 2019, that looked at very similar kinds of things to what Felitti and others did in their study. and pretty much came up with the same kinds of findings. Over 60% of participants, and these are state level kinds of indicators now. Over 60% of participants reported at least one adverse childhood experience. About 16% experienced four or more ACEs, and then the risk indicators were the odds ratios here reflecting level of risk related to ACEs about the same. So this is the short video. I don't know if I'll be able to show this or not, and I always hesitate with audiences like you all who are very educated around the health kinds of concepts here to show such a basic video. But let me see if I can show it. Has anybody seen this, by the way?
No.
Okay, it's worth it. I share it with social work professionals and others who are working in the field because it gives a good sort of sense of the ways in which adversity, childhood experiences relate to brain development and some of the disease pathways. So let's see, how do I do that? How do I need a mouse to try to connect on this.
The keyboard, if you could pull it up.
Let's see.
Try that.
Thanks.
Great.
I thought they'd get it. One sec. Nope. Sorry about that.
That's okay. Anyway, this is actually it's a uses animation to talk about the ways in which early childhood adversity impacts the brain and body and how it manifests in later problems and what we can do to be thinking about ways to sort of interrupt that cycle.
Could I ask
Sure.
the list of adverse experiences were family focused.
Yep.
There's lots of childhood adversity that wouldn't be covered. So
That's
I'm
right.
thinking of countries where at war, where children are exposed to chronic stress.
Yep.
And I don't want to disrupt the flow, but if you could say, do we find the same outcomes where a population experiences that thing, or whether some of these outcomes are specific to intrafamilial events?
Yeah. It's a great question, and actually one of the critiques that has been leveled against the whole kind of ACEs framework here in the United States anyway, is that it's very narrowly focused on household dysfunction as they talk about it. And so, to the question, I think that were we to look in context, and even actually in the United States, if we look at certain neighborhood contexts, for example, that have much higher levels of socioeconomic disadvantage, crime and violence in the neighborhood, those become very pivotal and very important risk factors for children. So the range of things that kids can be exposed to certainly is broader than what the ACEs framework suggests, but the sort of the ways in which ACEs are related to outcomes is very similar. So the effects of stress on the brain and body are going to be the same, regardless of the stress the kinds of stress or adversity that they encounter. And that notion of an additive kind of effect, or what they call a dose effect, is likely to be the same as well. That the more and the more chronic and the more types of exposures that children have, the worse are their outcomes typically.
So, in just, so we put this in the discussion later. I'm thinking, I'm not talking about childhood, but adults. PTSD in American soldiers, PTSD in Israeli soldiers.
Yeah.
Very different rates. Now,
The prevalence.
Yeah. What could account for that? One is, once again, a common experience that everyone in one country goes through. A rare experience. I mean, what proportion of people in the U.S., they come back, nobody to talk to.
Yeah.
So it's the shared adversity. Does that modify or serve as a major buffer in determining whatever the outcome is?
I guess I would offer that it probably has more to do with the protective and resiliency factors that extend beyond the individual and the individual's experience in that context. So in other words, as I'll talk about a bit later, social support becomes a hugely important protective factor for kids, and it is for adults as well. And we're certainly beginning to look at adult kinds of outcomes as well. So I wonder the extent to which there are protective and mitigating factors that could explain the difference in prevalence that you're talking about. But it's a great question. I think we should be kind of thinking in that way. What are these, the experiences that differentiate people who have similar kinds of adverse experiences? So let's come back to that. Okay, so let's see. Continuing on. I think.
It seems to be.
Yeah, Kevin's not moving now.
It's not moving now.
Yeah.
Perfect. 1 sec. Trying to. There we go.
Okay. So this issue of how adversity impacts individuals is one that has been, sort of consumed the field now for a number of years. Jack Shonkoff, who many of you may know, wrote a really nice review article. This is now 10 years old, so it sort of shows how quickly things change. But he talked in this article about the impacts of toxic stress and the ways in which cumulative exposure to stress leads to wear and tear on the body and actually speeds the aging process, such that you can see changes in the immune response leading to the onset of chronic disease. And it's one of the things that we're beginning to look at in this longitudinal study that I'll talk about in a moment. Dante Cicchetti and others offer a perspective that they call the developmental psychopathology perspective. This is more a kind of social sciencey way of thinking about the ways in which adversity impacts individuals over the life course. And we really do in our work, and others do too, take a life course kind of perspective in thinking about children's exposure to adversity. And what they say here is that child maltreatment is one very prevalent form of adversity. Initiates what they call a probabilistic path marked by increased likelihood of repeated disruptions. And they talk about this idea of a cascade of maladaptation. And what they mean by that is that there is this kind of very strong person and environment interaction that we can see unfold over the course of time, such that the early symptoms of or sequelae of abuse and neglect, such as poor affect or dysregulated behaviors, insecure attachments, manifest in later problems if the person and environment interaction is conducive to the ongoing exposure to risk and that kind of support of risk processes. If, on the other hand, the person and environment interactions are more supportive of resilience, in other words, that the mitigating effects of the environment are actually stronger than the risk effects, then we see less a connection between these early sequelae and the later problems. So what we try to do in our longitudinal work is to try to zero in on these person and environment kinds of interactions and the ways in which individuals particularly become resilient to the effects of early adversity, child maltreatment in particular. So this is kind of a silly slide for people like you, but just so everybody knows what I'm talking about when I'm talking about longitudinal studies, this is where we follow the same individuals over time. And we're looking here particularly at continuity and discontinuity in risk and risk processes in particular, and things that predict both the transmission of risk and then things that interrupt that cycle. So let me tell you real quickly about our longitudinal study. This was a study that started in the 1970s, believe it or not, and has continued to this day. We actually have 2 grants now that are supporting data collection in the field. I'll talk about those in a moment. But these were the 4 prior assessments that were done. So the first one was when individuals were recruited to the study. About half of the sample at the time was from child welfare agencies. This is from a 2-county area of eastern Pennsylvania, actually. And then the other half of the sample were recruited from non-child welfare group type settings where they could be. The idea was to have them serve as a comparison group to a certain extent. 457 preschool-aged children, 297 families. So we do have siblings in some cases represented in the study. It was a fairly gender-balanced sample, and about 60% of the families were from poverty. So when we just prior to our current assessment, when we assessed them last was in 2010, and we looked at a variety of things, current experiences, interpersonal relationships, crime, and antisocial behavior. All of these things have actually been looked at earlier phases of the study as well. And I should say that one of the things that really differentiates this study from others is that we collected at the very start of the project multiple forms of data on child abuse and neglect. So, for example, we have child welfare case record data for those who are involved with child welfare. And then we have parents self-report. So they're reporting on their abusive and neglectful disciplining of their kids, not just for the child welfare sample, but for everybody. And this is both a strength and a curse in some ways. Anybody want to take a venture guess as to why this is a curse, to have multiple forms of data on the same concept? They don't match at all. I mean, actually, that's an overstatement. They do match to a certain extent, but there's very low correspondence, for example, between child welfare records and parents' self-reports. Parents actually were much more forthcoming about the discipline strategies that would register as abusive or neglectful than was what was reflected in the child welfare records. And it's actually not a surprise because we know that those families who come in contact with child welfare are oftentimes more so from poverty, and SES, socioeconomic status, is a very big predictor of child welfare involvement. So there are a number of things that would explain why we don't see high correspondence. But anyway, it complicated things from the start of this project because it became a question as to what data do we use when we're looking at later kinds of outcomes, and we've tended to rely much more heavily on parent self-reports and for a variety of reasons, and I can say more about that if there are questions. So we have published over many years of, I would say I've actually lost count, but I think around 60 or 70 papers from this project. Early on, we did actually publish papers on the correspondence between different data sources. We also looked at the frequency and severity of child abuse subtypes. When kids were in elementary school, we looked at early manifestations of abuse, positive coping in children and families, and when they were in adolescence, we transitioned to looking at things that were more adolescent-like, like violence and delinquency, school dropout, other forms of victimization. Then when we got our funding from the National Institute of Justice and NIDA and others, we were looking at predictors and pathways to substance use and addiction. We're looking at stress and health and socioeconomic marginalization, so a bunch of different things. And then most recently, we secured grants from the National Institute of Child Health and Human Development, NICHD, to look at the relationship between child maltreatment and chronic disease. And we also received a grant from NIA, from the National Institute on Aging. So this is the NICHD grant, the AIMS anyway. And this is actually the first time that we've collected biological data. So this made me a little bit nervous, and I resisted this for a long time for a variety of different reasons. But we are now collecting liquid blood samples, and we're comparing that to other self-report data we have on adult physical health. And then backtracking and looking at how child maltreatment, as well as different forms of stress in and outside the family, actually, relate to these health indicators. And then layering on additional questions about resiliency and insight timing and adaptive coping. And then also analyzing gender differences. So again, with our gender balance sample, we can ask questions about male-female differences in these predictors and pathways.
Can you talk a little bit more about the types of data collection that are, so are you also including biological samples?
Well,
and are you collecting, so is the health data, is that also report, is that record, are they actually coming in?
They're not having physical exams. We have trained interviewers who are going out to the homes and actually doing, taking the blood samples and doing height and weight and other kinds of things. These are adults, but they were actually our kids when they began, right? So the kids the kids of the study are now approaching 50, 40 plus years after the study began, and so they're the ones that we're kind of focused on. Actually, in a moment, I'll tell you about the parents of the now adult kids and what we're doing around them as well. But this particular study is looking at the kids.
Children of the adult kids.
We did ask the parents of I always talk about this as G1, G2, G3 kind of thing. So the parents, the adults, these folks now that we're taking the samples from are our G2 participants. The G1s are their parents, and the G3s are the kids of the G2s. We have not assessed directly the kids of the G2s, but we have asked the parents, the G2s, about their disciplining strategies to look at the cycle of violence that continues oftentimes in families and their discipline strategies. So we use the same disciplinary practices protocol that we did with the kids' parents when they were parenting, if that makes sense. Yeah.
Are you using an allostatic load index? How are you scoring the biomarkers?
Yeah, that's a great question, and you all in some ways are probably more expert than I when it comes to these kinds of things. We're collaborating with a couple of people who are helping us kind of think about that. My understanding is that the sort of traditional allostatic load kinds of measures are a little bit dated at this point, and that there are newer ways of thinking about indicators of aging using these biological markers. And so we're working with folks. Dan Belsky is a person, I think he's at Duke, who was one of our collaborators who's helping us come up with an index, and he was kind of guiding us around the markers that we were collecting and those kinds of things. So I can't speak in greatly sophisticated ways about it, but we are kind of looking at the newer ways of modeling allostatic load.
And sorry, another question. Are you looking at taking samples from the different like epigenetics?
At this point, no. Again, this is our first foray into biological kinds of data, and so I feel a bit like a novice, I have to say, when it comes to this. And so it'll be interesting to see what the data allow. I mean, it was actually a very difficult thing to get funding to collect biological data because many in the field feel like we already have these answers, but the large majority of data come from cross-sectional studies where we're asking people to retrospectively recall events of the past, and there are all sorts of problems with that. And I could go on for hours about why that's a challenge. So,
I'm curious in a study section when they're reviewing a work like this, and there will be within the group people that are heavily focused on genetics.
Mm-hmm.
And those contributions to behavior. So generations are also sharing genetic commonality, and how much might that explain? Does that come up as an issue and suggestions on how that might be disentangled?
Yeah, it's a great question, and it hasn't come up directly in this study, but I've been part of other longitudinal studies where it has. I was part of a study when I was I was telling people that I'm new to the University of Michigan. I've actually been here for a year and a half, spent 25 years at the University of Washington, and there were a number of studies that were going on there, actually one in particular that sort of led me to really zero in on this particular issue. It was similar in the sense that they had followed individuals over an extended period of time. It was a school-based sample, about 800 participants, and they got a lot of money actually, to do a genetics study. Over 5 years, they got to the end of it and found that there was absolutely nothing that they could show in the way of genetic effects, or the way in which you could model genetics. And they were working with folks who clearly knew what they were doing. So I don't think it was for lack of understanding and methodological expertise. And so the two hypotheses from that were that the sample was too small to detect this kind of person genetic or genetic environment interaction. And then the other hypothesis was maybe the things that they had chosen to look at simply were not viable. And so, as I understand it, again, this is not my area of expertise, genetics certainly, but as I understand it, it's still a bit of a crapshoot as to sort of what you focus on and how you bring those kinds of things into studies like this, and whether even you have the statistical power to test the hypotheses. And so, as I said, the challenge for me, for our team, was more around convincing people of the benefits of looking at biological data in longitudinal samples than whether or not genetics was important. Clearly it is, and so genetics are there.
seems like there may be some potential to exploit the family nature of the fact that there are siblings, right? I don't know if you have any identical twins, for example.
Yeah.
But that might be probably not.
Probably, we actually know. And as far, I mean, we may have twins, but not enough to give us anything. In fact, I was on a study panel with folks who the Caspi study. I'm trying to remember what the name of it is. Anyway, there's a study based in the UK that's a twin sample study, and we collectively participated on a study group at CDC where we were looking at similar kinds of resilience processes. And it was interesting where they were kind of comparing and testing the same hypotheses as we were, and essentially arriving at very similar kinds of conclusions. Again, that's an N of one, right, in comparison to the other studies. But what they were coming up with in terms of resiliency factors were actually not that different, even accounting for the genetic, sort of differences or similarities, I guess, in those. Who knows? I mean, there are lots of questions, I guess, that could be asked, but I don't think we can ask those kinds of questions with these data. Anything else on this? So this is the other study, just real quickly. Fortunately, we got funding from the two sources at the same time, more or less. And this is our project from the National Institute on Aging, where we're asking the question. This is another kind of novel question, troubling one if you think about it. The extent to which kids who were abused and neglected when they were young are at higher risk for abusing and neglecting their parents when their parents enter old age and become dependent on them for care. So it's an extension of this cycle of violence kind of hypothesis that we and others have certainly explored. But there's absolutely no longitudinal data to address this question. There's a lot of speculation that actually kids who have been abused are in fact at higher risk. And I should say that the most, as I understand it, the most common caregiver is in fact the child of a parent. And so the likelihood is that many of the kids who did in fact experience abuse will in fact become caregivers at some point to their older age parents. And so it'll be interesting to see what we see in this way. We're also looking at the continuation of intimate partner violence using the conflict tactics scale for those of you who know it, and the Women's Experience of Battering scale, modified version. And we've traced kind of partner violence and its relation to child maltreatment over many years as well. And so here we're continuing that into middle life. So this issue of kind of the continuation of risk and risk mitigation is one that obviously drives a lot of the questions that we're asking with our data and that others are too. And the facts are that there is a connection, obviously, between ACEs and child maltreatment in particular, and later outcomes, health and otherwise. But there's also a great deal of evidence to suggest that there's a great deal of discontinuity in that pathway. In other words, there are many individuals who don't end up suffering from the same, from these kinds of sequelae that studies suggest that are more likely among individuals who encounter adversity. So it raises this question about why, and that kind of helps us kind of think about this notion of resiliency. And that idea of resilience is really kind of at the core, at the center of the work that we're doing on our study, and has been an interest of mine for a long time. And what's interesting about this study of resilience is that it actually differs quite a bit from where the field was when we began to sort of ask these questions about protection and mitigation. So the common understanding early on, and I'm thinking now about 30, 40 years ago, when people were really kind of, this idea of resilience, the focus was really on resilient traits and the ways in which individuals could or were not resilient. But over time, it became very apparent that this notion of thinking of resilience as a static quality was wrong. And part of the way in which we got there was to actually do longitudinal studies in which we were able to sort of document and track individuals' behavior and functioning over long periods of time. And so when we look at resilience in our study, what we see is essentially what this figure suggests, which is that you can choose a time in the life course and look at an individual's functioning, and how they're functioning is highly dependent on their exposure to protective or mitigating factors and risk factors. So when protective factors like social support, individual strengths, and this could be certain temperament qualities and various other kinds of things, positive environments, when these things outweigh the risk side of things or the vulnerability, then individuals appear more resilient. If, on the other hand, the vulnerability factors or the risk factors outweigh the protective factors, then the balance shifts in the other direction and individuals don't appear resilient. So it's kind of an interesting, shift on this idea of a static quality or trait that we can refer to in thinking about individual functioning. This is a figure that was published by Ledbetter and colleagues a number of years ago that illustrates this concept. They show individual competence along the vertical axis. You can think about that as resilience as well. And this line is kind of a reflection of the variation in levels of competence or resilience as a function of protective and stress processes. So if you follow individuals over time, right, the extent to which their competence is going to be lower or higher will be dependent on the balance between the protective and the stress processes. And that is precisely what we find in our longitudinal research as well. Yeah, please.
So, sorry, this is slightly unrelated. I'm wondering a little bit about construct validity. And it's like every time I read a paper on, okay, so, this is the prevalence of ACEs, and this is the correlation with badness, right? I keep wondering to myself, what exactly is being measured? Because psychological abuse varies in intensity, right? What one person may label that as, kind of psychological abuse may not be perceived that way by others. And so I never really understand. It's not even just so much what are we talking about, but also the fact that they're almost, in a lot of these studies, they're weighted equally, right? Mm-hmm. So it doesn't seem like the effect of what one person might call psychological abuse is the same across all. I don't know. It feels like almost an impossible measurement.
Yeah, well, it's an impossible measurement problem on both sides, on the adversity side and then on the resilience side, exactly. Right? Because this is another great example. People think about resilience and talk about resilience as if it's one thing, but it's really, the measurements are all over the place, right? And so when we talk about like competence and resilience, what are we talking about? The truth of it is that there is incredible variation in and across. Even longitudinal studies have, the few of them that there are in the way that we're measuring these things. And it's one of the reasons that I and others write papers to say we need, more consistency and uniformity in these definitions, because otherwise we're just, we're confusing the issues, right? And we're not making a very solid case for, how these things unfold. Anyway, it's a good point. I don't really have an answer or response. I think you're point on. You're right on. I think that is a concern in the field that we don't talk about these ideas or concepts in a consistent way, and it clouds the.
Well, it's about the weighting, right? There's some of these are just like psychological abuse, sexual abuse. Some of those are like just orders of magnitude worse, right? Yeah. Than some of the other ones that are considered different.
Well,
it's considered
right, and it's one of the major concerns. In addition to the ACEs, again, I'm talking here about the Validity type ACEs study. One of the major concerns about that study, not only is it cross-sectional, but this issue, is very much at play. That they treat sexual abuse the same way they do having a family member who has mental illness. Now, any of us who work in practice know that they are not the same, right. And that, as you say, severity, chronicity, also are issues, right? So kids who are exposed to physical child abuse, let's say, in a sporadic way, will appear very differently than those who are exposed to chronic forms of physical abuse, where they have nobody to turn to. And those kids, that second category, will actually be worse off, as we might suspect, right? Because it's a very different experience. But we don't typically, or most people who do this work don't typically take those kinds of things into account, which is why, going back to these, the aims of our grant here, why we say, we actually measure these things. And in fact, we measure these things with lots of different data sources. Give us an opportunity, to compare the effects of chronic physical abuse to chronic sexual abuse. Let us, compare emotional abuse to neglect and some of the outside external risk factors. So we try to do that. It's really difficult analytically, in part because those things are so highly intercorrelated, with the exception perhaps of sexual abuse, which is a different beast in itself.
Yeah, and my last. I'm sorry to just have so many questions about the literature. I'm sorry if I'm mixing. I do also wonder about this notion of so in order for us to care about ACEs, right, there has to be something special about the exposure occurring in childhood, right? And mechanically, of course, if you look over the course of a lifetime, you would expect, just by the fact that children live longer, there are potentially more lost quality-adjusted life years, right, just based on the fact that they live longer.
Yep. But
there's also has to be an interaction effect, right, an age-specific effect that it is worse to have these exposures in childhood relative to adulthood. That there's something, if somebody, I don't know if there was a field of adult adverse experiences, but, right, we have to believe that, and I do believe, I mean, I don't know if it's proven, but I do believe that there's something worse, right, because of the development of having this in childhood versus adulthood. But it also seems to me that one needs to control or account for all the bad stuff that might happen, other adult adverse experiences that may occur in adulthood that perhaps might be related to the early childhood experiences or could be completely independent.
Right, and so you're making a case for longitudinal research, honestly, right? Because we do that. We try, when we look, for example, at adult exposure to domestic violence or inter-partner violence, we account for child abuse and neglect, or we try to look at them in tandem so that we're not, sort of over-attributing kind of the causal effects to one versus the other factor. So you raise another couple of issues. One is developmental sensitivity, and there is some work to suggest that exposure to ACEs at certain points of development is worse than others. But it also, I think this other question or point that you're making raises other consideration of how we sort of differentiate adult, exposure to adversity from childhood. And the sad reality, however, I guess, is that most adults who experience adversity, with exceptions, clearly, are also those who experience adversity when in childhood. And so, this notion of polyvictimization, for example, or cumulative exposure to risk, runs very strong in these studies because we realize that, these kids back here who have been exposed to physical and emotional abuse, I can say for certainty, are much more likely to be, to experience inter-partner violence when they're in their early 20s and 30s and 40s, and probably will be the same people who will be at higher risk for perpetrating, abuse against their formerly abusive parents. The other sad reality is that we have, with the health kind of focus, I didn't mention this before, but, we have 5% of our sample who at age 45 plus has died. And that's, it's a very high risk sample, and, the effects of these early things you can see play out in lots of different ways over time. But it's one of the values, I think, of being able to study, these kinds of experiences over time and across the life course. So hopefully we'll be able to continue this for more time than we have already.
Looking at the list that you had there in the aims.
Yeah, I think about that.
And you talked about the childhood experiences, people who have been physically abused, sexually abused as young kids. You said much more likely to abuse
or be abused.
Right, when they're in a position of authority. And I'm just wondering, in terms of the negative outcomes, we would say that being abusive would be a negative outcome. But the explanation for that, you could go to learning theory, right? This is a way, how do you cope with whatever? This is, you just lose it and act out. Some of the other outcomes might be mediated by a very different mechanism. And I'm thinking about the literature, you talked about allostatic load, the neuroscientists looking at cortisol reactivity. So in animal species exposed to chronic stress, the normal response is you're exposed to a stressor, you get a brisk cortisol burst, and then it comes down to baseline quite quickly.
Yeah.
In the chronic, uncontrollable, it doesn't really go very high and it stays high, which is part of the mediation for those negative health
Sure.
outcomes.
Right.
But that would be a very different mechanism for a different set of symptoms.
Yes.
Is the literature sort of saying here you have these negative experiences, different mechanisms at play, which might account for different outcomes?
Yep.
There's the somebody abused and perpetrating violence on somebody else.
Yep.
That's more learning, modeling.
Yep.
And
Well, so let me go back to this this figure here. I mean, the literature is very clear that the early sequelae of abuse, let's stick with child maltreatment for a moment, are fairly consistent across studies. And so the biological sort of measures that we were talking about, I think are sort of newer to the fold. We haven't done as good a job looking at the impacts, for example, of stress in the brain and the ways in which we do know that there are structural changes and functional changes in the brain. But the literature is perhaps strong, most robust in this area of early social manifestations of adversity, probably mediated by some of the effects on the brain. So, for example, kids who experience abuse have much more difficulty regulating emotions. Right, and so they're at risk, for example, even at a very early age, kindergarten age, for lashing out at other kids in aggressive ways. They're at higher risk for perpetrating bullying, as they transition into the adolescent. And so, I think that there are some common threads, but you're also right that I think the theories that we use to sort of explain them sometimes don't converge on a common understanding of the ways in which these things work. And even in grants that we write, like when we write about, if I'm writing a grant on the continuity of violence, right, the cycle of violence that exists in families, I'll draw heavily on social learning theory, or draw heavily on developmental psychopathology. I don't talk so much about the biological mechanisms, although I do that a little bit more now that it's becoming more well known. When you talk about aging and the effects on health, then that becomes a very strong kind of, through line, that we kind of feature. And so maybe one of the things the field hasn't done as good a job as it might is bringing those theoretical perspectives together in more synthetic way to help explain the continuity and discontinuity. But you're right. I mean, I think that the different. I do actually think that there are different processes that unfold. Some more social, some more not social or biological or whatever. But I do think that common kind of biological impact of that early stress exposure is probably something that we should be kind of thinking much more directly about and trying to measure in these studies.
yeah, no, thank you.
All right, so let me see if I can zip through the last part of this. Okay, so I just wanted to kind of highlight the fact that there was a good article. This was actually written for a social work audience, but fairly sophisticated, talking about the Neuroscience of Resilience, written by Hunter et al. In 2018. I'm happy to send it on to anybody who would like it. And what they talk about here is this notion of resilience and the fact that it's not a return to normal necessarily, but a process of adaptation and recalibration. They talk about this idea of adaptive plasticity and also some of the therapies, interventions that are actually not just in this article, but from other places as well, that we know to be helpful in rebalancing or promoting this adaptive plasticity. So even things like meditation, aerobic exercise is shown to have some effects on brain functioning and on social behavior. Mentoring and social support, cognitive behavioral therapy, TFCBT, some of you are familiar with. And of course, we have the drug therapies that we know to be helpful with PTSD and other kinds of symptomology. I have been focusing with my colleagues more so actually on a broader kind of policy message about prevention, writing about the importance of primary prevention, of course, for child maltreatment, but also talking about some ideas around universal and blended prevention strategies. Is any of this familiar to anybody? This kind of public health framework? Anyway, what this is a public health framework. And what this says is that we can think about prevention across a variety of different buckets. We have our universal strategies, which are programs that are intended for all individuals regardless of risk. We have our selective strategies, which are intended for people at slightly higher risk for a particular problem, and our indicated strategies. So many of the things like drug therapies or TFCBT would fall into this kind of indicated bucket, right? They're intended for kids or adults who've experienced trauma and are manifesting symptoms of that early adversity experience. So here I'm talking to people in the medical field about medicine, but these are kind of the examples, right, that folks talk about. So public health smoking ban would be an example of a universal strategy, right, intended to lessen, chronic disease, daily aspirin for men over 50, which I think has been debunked. Is that no longer a driving theory? Anyway, that is more a selective strategy. Cholesterol-lowering drugs. Then in education, we have things like public education, obviously education being available to all. Head Start for low-income children and families being a selective strategy for families at higher elevated risk because of their exposure to poverty. And then this RTI Tier 3, so the response to intervention, Tier 3, individualized intervention. Again, TFCBT would be a good example. So the response to intervention is this multi-tiered framework that is actually replicating the public health model in school context. And Tier 3 is this kind of indicated approach to
What is RTI?
response to intervention. It basically says, let's kind of think about interventions in schools using universal selective indicated approaches, and Tier 3 interventions are like for the high end, kids who are symptomatic. Okay, so the benefits. Actually, I should say that when we've been writing about this, we've been talking about blended strategies, which is blending universal strategies and selective. So it's kind of saying let's kind of do more in this area and perhaps a little bit less in this area. Now, I know that sounds somewhat counterintuitive, but there are reasons why universal and selective strategies are perhaps our better bet at a population level and over the long term. And so these are some of the reasons. So obviously, universal strategies and selective strategies reach more people. They have the tendency of avoiding stigma. They don't place stigma on individuals who are in need of services. They're typically less expensive. There is clearly evidence to suggest that they have a stronger effect on the population, so health of the population, increased access to services. So one of the worries that I have working in schools is that if our focus is on TFCBT, for example, and we're putting all of our eggs in that bucket, there are a lot of kids who are asymptomatic but have been exposed to trauma and will eventually manifest symptoms that they aren't currently. And so we're missing the opportunity to engage with those kids because we don't spend enough time thinking about universal or selective strategies. So another benefit is that it tends to sort of bring us more to this kind of focus on strengths and resilience, again, talking about the benefits of universal and blended prevention strategies. And then this is my last slide, and it looks like we still have a couple of minutes anyway. So programs like TFCBT are used quite extensively, increasingly so, in schools and in other settings where kids who've experienced adversity are spending a good deal of their time. But SAMHSA, among others, and I would kind of put myself in this bucket too, are really pushing us to think about not so much individual strategies around trauma care, but more systemic, more systems-focused kinds of approaches. Again, for many of the reasons that I just talked about with respect to universal and selective strategies. And what a systems-oriented, trauma-informed strategy looks like is kind of spelled out here. So it's one in which individuals who work in a setting, envision a school setting, for example, or healthcare setting, or child welfare setting. It's where individuals actually realize the widespread impact of trauma and how individuals can move toward recovery. It's where those professionals can recognize the signs and symptoms of trauma in others, children and otherwise, and where they respond by integrating knowledge about trauma into policies, procedures, and practices, and where they actively seek to resist re-traumatization. And this is kind of a big deal, this last point here. So again, my focus has been primarily on schools. And one of the biggest concerns about the way schools operate is that they actually actively perpetrate acts and activities that are re-traumatizing for kids. So they can be as simple as calling kids out in school and making them feel uncomfortable to things that are much more obvious, like suspending kids from school or expelling kids for low tier, low severe, not particularly severe kinds of acts, sometimes like bullying. And the challenge is that schools have to respond, right, in a way that's going to keep kids safe. On the other hand, they're driving the kids who need schools the most as a protective mechanism further away from the education system. And by doing that, also sort of engaging in this practice of disproportionately disadvantaging kids of color, because we know that suspension and expulsion is much more likely to be used with black and brown kids than compared to white kids, and that's a problem. If we're kind of using this model of implementing individualized interventions in a system that is not trauma-informed, we run the risk of not only, again, stigmatizing kids who have to receive services because of the symptoms that they're manifesting, but we're also missing an opportunity to really restructure, re-engage, and reform systems so that they are more responsive to every child, regardless of their level of risk. And that I think is something that at least I'm thinking a lot about these days, how to do that. So with that, I'm done, and I'm happy to take additional questions. Okay. Go ahead, Lisa.
Thanks for such a thought-provoking talk. So my question goes to your second to last slide around prevention strategy. And you did answer part of my question about when you're thinking about prevention and specifically targeted prevention strategy and risk-based prevention, you then implies that there's screening.
Yep.
And so where is the screening happening? So is it in schools? Is it in pediatric primary care? There are other places? That's my first question.
Yeah. So the reality of it is it's not happening very often at all, actually. But where would it be located?
Yeah.
I think I worry about doing that in schools, in part because I don't think schools are equipped to respond to the adversity that they uncover. In fact, I have a student, the Doris Duke Foundation had for a number of years a fellowship program, which is really an incredible thing, where they funded pre-doctoral students who were doing work around prevention of child maltreatment. And one student who's based in Minnesota is actually doing a pilot of a screening protocol in a school setting and trying to understand, how does that work? What do people think about that? I have real worries about it, honestly. I think if systems were more equipped, if schools were more equipped, then, that would be one thing. But I think we're kind of putting the cart before the horse kind of thing in that way, because we're uncovering things that then we don't know how to handle. So I do know, though, at the same time, that there are a number of colleagues who have really been pushing this idea of embedding screenings for adversity in pediatric healthcare settings.
I react to that just because in terms of what are they prepared to deal with.
I know, it's the same issue. I agree.
So my second question is just a comment. So, this concept is less expensive per person, but important to recognize that prevention is often there is an incremental cost that may be, but it's at the population.
Yeah.
And so often our prevention and screening end up to be, but or buying benefits from that time. But I think it's important to consider.
That's a good point. And there's also a concern that some people have floated around universal strategies in particular, that as we increase opportunities for primary prevention services, that the individuals who will actually benefit are those who already benefit from the services that are available, probably something you're very familiar with. So that's another worry, but I totally agree with that. Yeah.
So I am very pessimistic about the notion of screening for ACEs. And the reason, especially in the context of the medical care system, I am a pediatrician. So I find this a little bit, this is way too late at that point, right? And I can refer you to this sort of service or whatever. It feels very, very, very just kind of tinkering. Like the big change is solve child poverty, give everybody a universal basic income, stuff like that, right? Getting people out of poverty, a lot of this stuff goes away. How do we? At the end of the day, right? It feels like we can try to try to screen, we can try to detect and refer, but fundamental societal changes are needed, right, in order to get rid of this, in order to get substantial. Yeah, so I don't know. It's kind of a general question. How do we get there?
Yeah. It's a great question, and a while back, I don't know, a year or so ago, I wrote an article that talked about the need to not only reform systems, but bring systems more closely together so that they're talking with one another and serving, kids and families, vulnerable kids and families more consistently and holistically. And in that article, I talk about there are a couple of foundations that are actually now getting behind this idea of sort of strengthening communities, right? So, rather than focus on any one system, that the way to combat the effects of poverty, all of the other factors that contribute to families really struggling, is to focus on communities and building capacity within communities. I think that there's probably something to that. And again, how we get there, I don't know. I mean, you know as well as I, but I do think that kind of focus on system reform, on community building, on capacity building, for me, holds much more promise than continuing to sort of go down this path of saying, okay, there's nothing we can do but treat individuals. I just don't believe that that's the right way to go, honestly. And so, it's that question, but I think you're absolutely right. Like, you kind of get to the end of the day and you're like, what the heck do we do with what we know, because it's pretty overwhelming.
Maybe you
Yeah, so you guys probably already know, but Nadine Burke-Harris is like the queen of ACEs, and she just first Surgeon General ever of California, and she is going to institute like universal ACE screening for California. So I think that'll be super interesting to see what happens with. She does a lot for the communities and stuff there.
So who reports?
Do you know where that's happening? The screening will happen like at the school level?
She's a pediatrician. She started at Bayview in her own practice, and she referred immediately to a mental health. And then she started the Child, Youth, and Wellness Center. So they have all of those like in one house, which is what she really wants for. But she would just do the screening and then move on like with the rest of her assessment because she's not equipped
Who's
to do
being
that.
asked the question? The parent?
I think about 12, they do some self-reporting, but the parent is reporting. So she made a tool where it was de-identified. It didn't matter which ACE. She just asked for a number. So then they don't feel like they have to report things or, like they kind of get around that. Her book, it just came out this year, The Deepest Well, is really readable. It's really, really interesting. But we're not here to listen to me. So I have a question. I am really curious. She pushes a lot about, in her practice, she does CPP, the Child and Parent Psychotherapy. That wasn't up here, and it wasn't on a lot of the other literature that I've read. So I'm just curious what your thoughts are on that, and like how, if it's so new that like we don't really have that much about it yet in relation to ACEs.
Yeah, I don't know the model particularly well, but I can say that there are programs like Nurse Family Partnership, David Old's program, which is a strategy of putting public health nurses actually into families, prenatally and having them work with families and whatever reduces risk for child maltreatment. Again, I think that there are examples that exist out there of evidence-based approaches. I don't think we have the answers yet. And in fact, there are differences if you look at meta-analytic studies, of how strong an effect any one program has. So I'm just really cautious myself of getting behind any one particular model because I think it then does the field a bit of a disservice, in sort of promulgating ideas that may not be as strong as the individual proponents might want them to be. So that's a long way of saying I don't really know, the details of that. But I do know that there are certain approaches that are worth kind of taking a closer look at for sure. Yep.
Can you help me remember a longitudinal study that was done in Hawaii?
Yeah.
I think it's
the Kauai longitudinal study.
Yeah, against all odds.
Right. Any order.
And what my recollection of it was that a factor that led to people overcoming their circumstances was a person who kind of cared about them, mentored them. And I'm just wondering in this literature, does that continue? Because I see the social support, that's a dimension.
Yep.
And then you think of Big Brother, Big Sister program. Is this still thought to be a strategy for not eliminating, but perhaps getting people back on track.
Yeah, I really appreciate you raising this. And in fact, that book, Against the Odds or Against Whatever It Is, it's really another really easily read book and very well done. It's now about 20 years old or even more longer or older than that. But yes, in fact, in our study, we actually, in the last wave, 2010, we embedded a series of qualitative questions at the end. And we asked people, drawing on life course theory, asking them about transitions and turning points in their lives. And these, again, are people who experience adversity, and many of them have, theoretically overcome some aspect of that. And many of them actually talked just about that very issue, about a mentor, about somebody, typically a teacher, in their lives who just simply cared and spent time with them and supported them. And if nothing else, it promoted that kind of concept of insight that allowed them to use their individual strengths to sort of, move on to a different space in their lives. So that, one of the things that I do believe is that individuals who consistently show, again, realizing that there's a lot of variability in how resilient somebody is over time, people who are consistently high functioning but exposed to adversity early on, both have some aspect of social engagement, social support, and they have the intellect and the ability to sort of use what they're receiving to their advantage. And we see that, we have students in our school social work who talk openly about their experiences, for example, of with adversity. And 201, they are really smart, engaged, intellectually capable, and they're individuals who can use, the gifts that they're given. If we can think about it that way from other people, and that mentoring capacity, that social connection is a huge part of it.
I mean, that's something that communities could do
Yes,
without stigma.
absolutely. Totally agree.
We are running out of time, so I wanted to thank Dr. Herrenkohl again for coming.
Thank you.